Welcome everyone to the webinar on how to make sense and treatment options for hepatocellular carcinoma in 2025. Now, I would like to invite our program director, Dr. Amol Akhade, to start the proceedings.
So, first of all, let me thank all my faculty who have joined across the world. Hello, Dr. Namrata and Dr. Ghassan, Dr. Louis, Dr. Ankur, and I think
Good
Dr. Tanios
evening.
joining soon. And good morning, good afternoon, good evening to all of you. We are from different part of the world. So let me introduce my first speaker, and Dr. Louis Gabriel Parra. He is a fellow in hematology and oncology from Colombia, and he will be our first speaker. So over to you, Dr. Louis.
Thank you, Doctor, for your invitation to be part of this conference. I will share now my screen. Please confirm that you see that, please. Yes, perfect. Okay, thank you. Good morning, colleagues, and thank you for the invitation to participate again to this international webinar. Today, I will discuss how we can integrate local, regional, and systemic therapy in hepatocellular carcinoma, an area that has evolved rapidly with the emergence of immunotherapy-based combination, updates in staging frameworks, and also new evidence that's supporting combined modality approach. So hepatocellular carcinoma or hepatocarcinoma remains one of the leading causes of cancer-related mortality worldwide. These statistics from United States shows that the recent global projections, both early stage and advanced stage of hepatocarcinoma, will rise dramatically over the next decade, driven by persistent HBV in developing regions and surge and MSLG in Western and Asian countries. This epidemiological change reflects broader shift in tumor biology, comorbidities profiles, and treatment eligibility. Therefore, understanding how to integrate different therapeutics modalities is increasingly relevant in this issue. Tumor heterogeneity is a central determinant of hepatocellular carcinoma behavior and major barriers to effective treatment. As shows in this slide, this heterogeneity drives tumor evolution and progression, promotes primary and acquired therapeutic resistance, limits the reliability of single biopsy biomarkers, contributes to the wide spectrum of radiologic phenotypes and clinical behaviors, supports a multimodal and sequential treatment paradigm. This slide presents recent advance in treatment in this type of cancer, and we can see about the time transition to immunotherapy-based first-line treatment, expansion of dual checkpoint inhibition, consolidation and sequencing of TKIs, integration of local, regional, and systemic therapies, rise of conversion therapies and downstaging strategies, the emergence of novel therapeutics directions and clinical implications. Local regional therapy are liver-direct procedures as ablation, TACE, TER, SBRT, HAIC, and this strategy could have different intentions as local tumor control, downstage disease, bridge to transplantation, and also provide palliation also. First, percutaneous ablations like radiofrequency and microwave ablation achieve excellent local control for tumors, generally less and equal to 3 centimeters, and selected 3 to 5 centimeter lesion with careful planning. Main limitation are size and proximity to vessels or bile ducts. Ablation offers curative intent comparable to resection and highly select early stage patients. For the other hand, transarterial therapies like TACE remains the standard for intermediate stage disease decision on conventional versus drug eluding beds, repetition, and combining approaches depend of tumor burden, vascular anatomy, and liver function. Transarterial radioembolization, as TARE, provides high rates of tumor necrosis and can be an alternative to TACE in patients with portal vein thrombosis or poor taste candidates, for example. And finally, SBRT radiotherapy strategy is effective, non-invasive option for local control in early stage tumors, unsuitable for ablation or resection, for oligoprogression also, or as salvage after other local regional therapies. Recently, the Barcelona Cancer Liver Group in 2025, 1 year ago approximately, presents the last update about the approach of liver cancer. And the goal of this new strategy is to provide globally applicable evidence-based and clinical practical framework for prognosis prediction and treatment recommendation in hepatocarcinoma, while incorporating the rapid therapeutic advances of the last years. The revisions of this topic include the traditional state to treatment linkage, a hallmark of BCLC group, but integrate a more nuanced patient-centered and context-aware decision process. The major change in this new approach include, first, integration of new therapeutic evidence. Second, dynamic and personalized prognosis assessment. Third, recognition of real-world clinical complexity. And fourth, and the most novel, introduction of CUES framework. This frameworks is the biggest conceptual advance in this strategy that adopt the CUES. CUES is a guide clinical decision making in scenarios where evidence is incomplete or multiple reasonable options exist. CUES stands of C, complexity, U, uncertainty, S, subjectivity, and E, emotion. If we reviewed this update, the key change in BCLC for 2025 regarding local, regional, and systemic therapies. First, preservation of stage-based recommendation, but a greater therapeutic flexibility. And also, the second part is the formal recognition of treatment state migration and sequential combined strategies. One of the more meaningful conceptual framework change is the explicit acceptance of treatment stage migration, or TSM, and the flexible sequencing. Patients may transition from local regional treatment to systemic therapy or vice versa based on response, hepatic reserves, disease evolution, treatment availability, and patients' priorities. Also, in this year, we obtained the last update in the ESMO Guidelines 2025, and they reinforced the central role of local regional therapeutics across early and intermediate hepatocarcinoma, aligned with advanced treatment, patient selection, and multidisciplinary care. This guideline emphasized the individualized treatment, evidence-based modality selection as BCLC, and the integration with systemic therapy appropriate. This guideline strongly supports abridging maintaining eligibility of transplantations, downstaging, expanding transplant eligibility, and integration with systemic therapy, especially when taste reforms develops, disease biology evolves, liver function decline after replace LRT, and the guidelines emphasize also timely transitions to systemic therapy to avoid deterioration of liver reserves. And we can show that in the advanced stage when BCLC for B and C include more IC therapy or no IC therapy, and BCLD include regional control focus in palliative care. Now, we review shortly the different systemic therapies approach that we have available in different countries. The first one in Brave 150 that includes comparison and test of bevacizumab versus sorafenib, Himalaya, tremelimumab, and durvalumab versus sorafenib, and Checkmate 90W that include nivolumab, ipilimumab versus lenvatinib or sorafenib. And finally, LIAP 012, the combination of lenvatinib, pembrolizumab, TACE versus TACE. Unfortunately, recently in 2025, ASCO meeting in Chicago, the LIAP 002, it shows that this phase 3 trial that evaluates lenvatinib pembrolizumab versus lenvatinib alone as first line of treatment for advanced hepatocarcinoma considered that did not accomplish or did not meet its co-primary endpoints that include OS and PFS. To show the integration of LRT into hepatocarcinoma, management depends on multidimensional assessment that combines tumor biology, tumor burden, local versus systemic, and vascular invasion of PBTT. Modern guidelines that I showed as ESMO and BCLC emphasize individualized multidisciplinary decision making. Modern care combines LRT with systemic therapy in a dynamic multidisciplinary framework, avoiding over-treatment and optimizing long-term outcomes. Recently, we have two studies. The first one is Emerald 1, which is a multi-regional randomized double-blind placebo-controlled phase 3 trial that include patients with unresectable non-metastatic hepatocarcinoma eligible for conventional TACE, Chalpuk A code 021, and no prior systemic therapy. The study includes 3 arms. First one, durvalumab plus TACE, and this durvalumab plus placebo for bevacizumab. Arm B, durvalumab plus TACE and continuous durvalumab plus bevacizumab. And Arm C, placebo plus TACE, and then placebo plus placebo. This study shows that the median PF increased from 8.2 months with placebo plus TACE to 15 months with durvalumab bevacizumab plus TACE, representing around 23% reduction in risk of progression or death with addition of checkpoint inhibitors, VEGF inhibition combination. And the second one is LIAP 012, lenvatinib plus pembrolizumab and TACE versus dual placebo. This study with the primary endpoint that include PFS per RECIST version 1.1 by BICR shows the green curve that lenvatinib pembrolizumab plus TACE remains consistently above in control arm through follow-up, indicating an early and sustainable improvement in tumor control when systemic therapy is added to TACE. On the other ways, Jian and colleagues from China conducted a systematic review and meta-analysis that evaluate the efficacy of local-regional therapy combined with target therapy and immunotherapy in patients with hepatocarcinoma and portal vein thrombosis. This study as key findings shows that these combinations significantly improve overall survival, OS, compared with local regional therapy alone or local regional therapy plus target therapy. Future directions of this in hepatocarcinoma treatment Next frontiers include a triple regimen, advance in biomarkers, adaptive immune monitoring, combination of TER plus IC, and integration of radiotherapy-based modalities. Several ongoing phase 2 and 3 clinical trials are exploring optimal doses, timing, and sequencing. Ultimately, treatment will likely shift a local-regional first paradigm of biology-driven, systematically ensured model. In summary, in conclusion, local regional therapy remains foundational in BCLB as Barcelona group, but its limitations are clear in the manuscript. Immunotherapy and anti-VEGF combinations are reshaping the landscape and offering new opportunities for deeper tumor control in hepatocarcinoma. The integration requires careful patient selection, timely transitions, and multidisciplinary oversight. The ongoing trials will define which patients benefit most from combined strategies and which should move directly to systemic therapy. And thank you, and I look forward for discussion with the team. Thank you.
So thank you, Dr. Louis, for this introductory talk. And can I share my screen? So let me share my screen. So before I start, can we introduce our faculty? So let me thank all the faculty who have joined, Dr. Namrata, Dr. Tanios, Dr. Ghassan, and Dr. Ankur. And thank you for joining from different parts of the world. And thank you for taking time out for this particular academic activity. I really appreciate all of you for that. And without wasting time, let me start with the panel discussion. So can I share my screen?
Yes, sir.
Okay. Okay. So are my slides visible?
Yes, they're visible.
Yeah.
Yep.
So we should talk about how to make sense of new data from management of HCC. And let me start that I have no conflicts of interest to declare. This is academic discussion is meant for guiding practicing oncologists to make clinical decisions in routine practice. In the beginning only, we thank all the clinical trialists and patients participating in these clinical trials for knowledge gained. Let us understand that no trial is perfectly good or perfectly bad, and every trial, whether it is positive or negative, pushes the boundaries for patient outcomes further. So this has been, of course, shared by Dr. Louis. This is the current overview of the HCC treatment. Unlike any other solid tumors, you have to understand this particular cancer, you have multimodality treatment and integration of that, the systemic therapy, the local therapy, and it requires multidisciplinary care because the treatment not only depends upon the size of the tumor, but underlying status of the liver, what is the underlying etiology, whether it is a viral or non-viral. So multiple factors come into picture. And that has been already shown. This is the BCLC current guidelines. This is under publication. And this is the flowchart. If you see here, for the end stage, it is the survival is less than 1 year. But at the same time, for the early stage, it is close to very high, but around 5 years. And in between, it is 2 to 2.5 years. So our entire effort is to see how can we make things better. Most of our patients, unfortunately, fall into intermediate stage or advanced stage. And that is where our role comes into play. And as you all agree, that multidisciplinary care involving medical oncologists, radiation oncologists, hepatobiliary surgeon, transplant surgeons, hepatologists, pathologists, interventional radiologists, all these things matter, but let us understand the patient is always at the center, and it has been shown in a lot of studies that those centers where MDC is part of the treatment, there is an improved overall survival for the patients. So moving on, let me start with Dr. Ankur. Almost all solid tumors, adjuvant therapy plays an important role. You take it even in RCC now, there is a role for adjuvant pembrolizumab for clear cell histology, but not yet for HCC. Any particular reason you can suggest? Is it because of
Yeah,
difficult
yeah,
biology,
yes, yes.
or what is your thoughts on that?
So, Dr. Amol, I feel that there are three or four pertinent reasons for that. First of all, we are clearly lacking any benefits across various trials which have been done in the past and the trials which are going and the coming trials. So, and we see Storm trial, which was a sorafenib adjuvant trial, which failed, and it was a landmark negative trial. So, if we see literature, there is lack of data right now, convincing data on OS benefit. Secondly, is that as other solid cancers, liver cancer is a different ball game. There's a background of cirrhotics and the drugs which we give, whether it is IO or anti-VEGF inhibitors or TKI, they all are metabolized. And we always know that liver cancer patient may or may not succumb by liver cancer, but certainly it's a liver failure which takes away the patient from us. Second point which I want to highlight is that the biology is different. So once we have done a definitive treatment in the form of surgery or ablation, then the secondary metastases which come a long way is having a different biology. So the concept of cirrhosis and the micrometastasis is, so the biology changes with time. So it may not be proven in an adjuvant setting. Third reason, which I believe is that against the toxicity of these drugs and the grade 3, grade 4 toxicities are so much in a cirrhotic patients, even if it is an intermediate or an advanced stage, it does not give us that advantage in the terms of OS benefit. So lack of drugs, toxicity of the drugs, and the behavior of this tumor, which is different from other solid cancer, so pushes us not to give adjuvant without any data. So this is my submission that this is a different cancer from lung, kidney, and other GI cancers.
So as a
So it
medical
has to,
oncologist, of course, I
yes,
agree that it's a difficult cancer to treat, especially in adjuvant setting. And this is one of the latest adjuvant study. Unfortunately, it is a negative study, IMbrave 050. And what is peculiar part is that post-resection for high-risk patients, and they have very nicely mentioned the high-risk features at the bottom: tumor more than 5 centimeter, more than 3 tumors, microvascular invasion, or minor microvascularization, that is VP1, VP2, or grade 3 and 4 pathology. So any of these risk factors, they tried to randomized between atezolizumab versus active surveillance. Initially, it was reported as RFS benefit was seen, but unfortunately, in the long follow-up, if you see, unfortunately, the curves are meeting each other. The RFS benefit has lost on the longer follow-up. And of course, in updated OS also, the hazard ratio is 1.26. So, of course, it's not entirely a positive study, but Dr. Namrata, as you all agree that every study teaches us something. So, any positives from this particular study?
Yeah, we
I
learned a
think
lot
what
that it doesn't work.
Yes.
that is definitely that let's not bring things that work in, like, it's not a slam dunk that what works in metastatic will work in adjuvant because of everything that has been mentioned. But I think what it does tell us that this is a very high area of unmet need. Like, we really need to work towards finding some options for these patients, because you can see how poorly they're not doing very well. Many people recur. There's like definitely an area that we all have to work towards. I know there's a lot of newer vaccine strategies, et cetera, being tested in this area, but just, I think, mostly points to that fact.
So unfortunately, as you see, the adjuvant pembrolizumab study, the Keynote 937, also has been declared as a negative result recently. There are some other trials going on about Checkmate
The
9DX
camera.
and Cambrai plus APA and
Mhm.
Emerald D2, Emerald 2, basically. But of course, we are looking forward to the studies. But the problem here is that the definition of high risk in the post-surgery, if you see the trials which are already going on, the definition is not homogeneous. There is a heterogeneous definition about the size, about the multifocality, about whether the VP1, VP2 to be included or not. So let me ask Dr. Ghassan that how do you define post-resection high-risk HCC in your practice, and what is your current strategy? I have conducted one poll here, and they say most of the people agreed that as of now only observation. But is there anything different that you do, and how you define high-risk HCC in your practice post-resection? Dr. Ghassan?
Yeah, thanks so much, Dr. Hadi, and congratulations, and thanks for inviting us today. So it's really quite important that we start with this important discussion about quote unquote potential adjuvant therapy. And to be fair, the perspective that we're taking at this point at Memorial Sloan Kettering is that sadly we're asking the wrong question. We're presuming that HCC is like any other cancer. It's a tumor that will invade and kind of like occupy space. Well, actually, it's not. If anything, HCC is embedded within the parenchyma of the liver. And as such, the question is or has to be handled in a different way. I like very much in the Ambrave 050 discussion that was brought in the publication. And if anything, it really brought in that, which Dr. Chi from Nanjing brought in, that after all, there are two different populations, at least two different populations that we are handling in that disease, the early recurrences and the late recurrences. And these are all based on biology. And at the same time, even the surgeons, our colleagues in surgery, will tell you that we do treat this disease differently. As we know, here in the US, in India, and anywhere else, most of the Western Hemisphere, we kind of make a margin around the tumor and take it out. And this is really what we do for all other cancers. Interestingly, our colleagues in Asia don't do this. They, if anything, they consider, like, based on that parenchyma component I'm bringing in, like in Japan, they consider the segment, all of it is quote unquote infected with the cancer, and they'll take the whole segment. So as you see, we're a mixed bag in regard to those studies, and that's why the question was not really brought up correctly to begin with. The drugs do work, but the problem is, are they already addressing the right question? Interestingly, though, we just saw in Berlin with Dr. Chi from Zhuang Qi from Shanghai, from Zhongshan Hospital, the CARE 009 study, which is quite impressive. They brought a different question is, can we do neoadjuvant therapy? And this probably was published on the same day as, in the New England, and really came out with this kind of impressive component of, are we maybe considering that maybe rather than doing a potential adjuvant, should we do a neoadjuvant therapy? Now, the downside only to that study that he did is that it was done only in China. And as we know, we really like to have global picture before we come to an answer per se. But I would say the future is not going to be more adjuvant therapy. I think we already tried, and it's not really working, not because the drugs don't work, but because really the population is not the right population we're addressing. The question is, with parenchyma involvement, would a new adjuvant approach or a quote-unquote peri-adjuvant approach, as also was brought in at the CARE 009 study, will be the way to go.
So thank you for this. So you think that probably instead of adjuvant, we should more focus on the neoadjuvant or the perioperative approach. So
Absolutely.
let us see, in future, whether we get any positive results. As you said, one of the trial done in China, whether it gets replicated in other parts of the world. So moving on, let me ask Dr. Tanios, there is a role of ctDNA in colon cancer, ctDNA in all other solid tumors. And this is a recent paper published in European Journal of Cancer showing that there is a role of ctDNA in predicting about the clinical outcomes for systemic therapy in advanced hepatocellular carcinoma. So let me ask Dr. Tanios, do you use ctDNA as a prognostic marker in your HCC patients? And if yes, in what setting? And what is your experience about that? Or do you think it is too early to use it in HCC?
Yeah, I think it's too early to use it across the board universally. Selectively, and with a discussion with the patient about what it means is going to be very important. I mean, these are expensive modalities, and your question about predictive. I mean, I think putting predictive in or predicts in the title is a bit misleading. This truly has no predictive role in essentially deciding whether a patient is benefiting from treatment or not. Now, there are dynamics to ctDNA under treatment, meaning, we've seen data, and this is one of them, about the dynamics of ctDNA and that how that correlates with, with treatment outcome. But the question, that comes back to us is, so what? What would it mean if you have a rise in ctDNA while a CT scan or an MRI shows you a stable disease or even a response or a drop in alpha fetoprotein? Do you change treatment or not? does that affect patients? Now, we do know that ctDNA dynamics may precede radiographic changes or even biomarker changes. However, the mark ultimately that would measure whether this is truly predictive, meaning allows you to switch therapy, and that switch therapy allows you to have an improved outcome. The only way to actually show this is to ask the question in a randomized setting. What we've seen is a lot of data in colorectal in the early stages that has been relatively disappointing in terms of the predictive sense. Still a very strong prognostic tool. But as you know, a prognostic tool only goes so far. Now, if we go back to the adjuvant discussion, now, can we integrate ctDNA assessment as one other dimension to decide on high risk versus low risk? Perhaps. But again, that question has to be asked, and you cannot ask the ctDNA question in isolation of everything else. It's other factors as well. So overall, what I would say is that for ctDNA, definitely prognostic. We frankly, at this point of time, don't know whether it has any predictive role or a role in actually allowing us to change therapy based on levels of ctDNA versus, at this point of time, just using it, as an additional tool, but not a major deciding factor.
Thank you. Dr. Ankur, you wanted to add something?
Yeah, I want to add. So since I have worked with a reputed hepatic surgeon, so I can recall two patients very clearly where there was a tumor rupture, iatrogenic tumor rupture during resection. So my surgeon felt that this patient needs adjuvant therapy. I'm talking 3 years down the line. And we at that time, we got both of the patient ctDNA through Garden 360, and we got a tumor fraction. One was 0.2% and one was 0.5%. So at that time we added lenvatinib. Tumor rupture was one of the indication of adding on. There's no data to it, but yes, I have used in two patients, and we got a tumor fraction of 0.2% and 0.5% in the blood. So that correlated or didn't correlated. The patient relapsed after a few months. But yes, this is the overcoming concept, which can later we have guidelines in lung cancer, in colon rectal cancer, breast is coming up. So ctDNA estimation can probably come up in some of the few patients who are at a very high risk. And probably we can add adjuvant on the basis of ctDNA if they are positive 4 to 6 weeks after a definitive treatment.
Well,
That's
I
what I
mean,
was.
let me disagree with
Yeah,
you a little bit. I think
I
you're absolutely right on the stand that a high risk. So you always have to think about a pretest probability and the value of pretest probability about how to interpret the test. If a tumor ruptured, your likelihood of a metastatic disease or submicrometastatic disease is already almost 100%. So of course you're going to find a ctDNA that's positive. So is the ctDNA adding value? And then to the question about do you just based on that consider adjuvant therapy versus other high risk or any other high risk which we've seen have failed so far features, and is that going to change outcome? What you're doing is you're treating metastatic disease, and we know the lower tumor burden responds better to treatment. So you frankly have to show that earlier intervention on supposedly metastatic disease is going to change outcome. Otherwise, it's just an expensive test that adds a lot of anxiety to the patient and to the physician and doesn't really change outcome. Namrata, I'm sorry, I cut you off.
Absolutely
was
right. So if we have
literally saying the same
yeah,
thing.
absolutely right.
Yeah,
Okay. So
yeah.
to conclude, basically, as of now, it is just should not be done outside clinical trials, and we still require more data to utilize it, either predictive or prognostic. So moving
Absolutely.
on, now this is where the situation becomes tricky in the intermediate stage, and I funnily called it as a matrix question, whether it is a blue pill or a red pill, whether you want to choose between SBRT versus TAR versus TESS. And as a medical oncologist, unfortunately, most of us are medical oncologists here. I could not get a radiation oncologist on board. But as a medical oncologist, we are trying to have this question whether the addition of IO will help to these patients, addition of IO to SBRT versus TER versus TEST. Now, just trying to summarize here the various data that is available of head-to-head comparison between SBRT versus TER or versus TER versus TEST and versus SBRT versus TEST. So what it shown more or less is here in this particular graph that overall survival is similar whether you use SBRT, TEST or TER. The local control is highest with SBRT, moderate with TEST, and with TER, again, it is on the higher side. But again, we have to choose the patients based upon tolerability, based upon the expertise available, and again, the TER has highest time to progression. So sometimes it becomes too confusing, and there are various guidelines. And there is a very nice word in BCLC guidelines. The decision making is complex, uncertain, subjective, and emotional. And that is what happens in MDTs when we sit down with everybody and try to figure out and which patient should go for that. Of course, there are certain guidelines based upon the size of the tumor, whether whether it is multifocal or whether it's solitary, whether it is a diffuse multifocal disease, what is the tumor thrombosis, so many other factors. So let me ask Dr. Namrata, starting from you, how you make these decisions in your MDT and how you select patients for TEST versus SBRT versus RFA, assuming that all the expertise are available. In India, unfortunately, in all centers, all expertise are not available. So discussion on limitation, but US, I'm pretty sure at your center, all the expertise are available. So how you go about it?
No, I think on a lighter note, I would say like whoever is present at the MDT that day, like just makes that decision, because these are all, as you mentioned, for like smaller tumors, right? If you have a solitary lesion less than 3, we typically tend to just take them for surgery if we can, like if they're single lesion less than 3 centimeters. But if you have like someone who has like bad cirrhosis, not a surgical candidate, everything, we typically do microwave ablations. And here at our center, like that's what we typically do for single lesions, and we save and TACE is our preferred choice in the first, like in the beginning when you have multiple tumors that we treat with. And then if patients don't respond to it or have recurrence after that very quickly of the same lesion and then we tend to bring in the radiation in both ways.
So Dr. Ankur, what is your thought? Do you agree it is
Yes.
whoever is present or whoever is the loudest in MDT is going to decide?
Yeah, absolutely. It determines the flow of our MDT, the hierarchy, the presence, those who are absent, and most importantly, what's available. Fortunately, we have all the facilities under one roof in our hospital. But yes, it depends upon what kind of lesion it is, what is the cost, because many of our patients are out of pocket, out of insurance. So the intervention radiologist, his presence, his expertise, VP1, VP2, TACE, TER, SBRT, the liver functions, the volumetric of liver, the amount of shunt fraction, TER 1, TER 2, TACE 1, TER 2 to see the angios. So it's a multiple factor, the cost, the performance status, the wish of the patient, agreement of the patient, expertise of the doctor, belief of a medical oncologist that SBRT to the main portal vein thrombus can be dissolved in 30 to 40% of the patient. Americans don't believe, Southeast Asian believe that. The SBRT to the main portal vein, your radiation oncology has an expertise or not. So these are multiple factors, both across the table, the patient party, your colleagues, your peers decides all those things. And the amount of adjunct lenvatinib, -1 lenva, TACE on 0, plus day of lenvatinib or upcoming IO. So all these matters when it comes to an HCC and the treatment modality. So it's a multifactorial, multimodality, and multidisciplinary, all has to take into account.
So to summarize, of course, all these modalities are good, but they are as good as the expert is available. And the decision is always complex, uncertain, subjective, and emotional, and it should be part of the MDT. That should be at least the basic thing that should be followed. But as a medical oncologist, we are interested that whether the addition of the IO to the intermediate state will be helpful. And there are two trials, Dr. Liu described them beautifully, Emerald 1 and LEAP 012. Unfortunately, none of them have OS benefit as of now. Both of them are toxicity issue. There is a discussion about what is the background, whether it should be TACE or TARE. And of course, there is a cost factor. So let me ask Dr. Ghassan your take on these two trials. I have put the toxicity table across, and I have put the poll also across, that suppose the patient has underwent TACE, should we add anything? 31% said yes, Emerald 1 should be the approach to go, but both of them do not have OS benefit. So let me ask you, Dr. Ghassan, what is your take? Will IO addition in this particular population be helpful? And what is that you do in your clinic?
Well, I love very much the responses that we got about the emotions that happen at DMTs. And it's fascinating to see how emotions evolve differently. I've been to DMTs in India, and definitely the emotions are very highly expressed. In the US, take my word, it might look like silent and quiet. Take my word, there's a lot of internal emotions that really just think, I hate this. So know that sadly, we are expressing those emotions because really we're not guided by data. And over here, everybody is pushing for their intervention. And I would really like to really think of those interventions as being more of vehicles to really deliver more of the systemic therapy, as the Emerald 1 and the LEAP 012 study at least tried. For that purpose, it's important to have a teamwork intervention. And the effort should really be between the interventional radiologist and the medical oncologist, like hand in hand, to ensure that really what's best for the patient. And here I'd like to point on three things. Number one, regard to the LEAP 012 study and the Emerald 1 study. And as we know, the survival data came out already for the LEAP 012, it was negative. But if you look very carefully, these populations are totally mixed bag. If anything, in the Emerald 1, they used the up to 7 criteria. In the LEAP 012, Jose Plove decided to use up to 8 criteria. Everybody would like to make a number, but nonetheless, everyone would like to be different. But ultimately, you look and you'll see that 50-50 beyond up to 7 criteria and less than up to 7 criteria. And these are totally different populations. And if anything, until we really consort the effort being, are we really trying to treat, and these are two important questions, are we trying to treat and see if we can enhance the value of the intervention, i.e. being TACE, TARE, TAE, by adding on checkpoint inhibitors in disease to begin with is supposed to be amenable for the intervention, like it was really seen in the first studies back in the 2000 by Dr. Lee and Dr. Love in regard to TACE at that time? Or are we trying to see if beyond up to 7 criteria, patients who really are amenable to systemic therapy, could we, by controlling disease locally in the liver, make any difference in outcome? And to give that matter, its point is, are we moving C to B or B to C? And our colleagues in China have done it smartly well in the work that they've done in Sun Yat-sen in Guangzhou, where very much it was published in JAMA Oncology back in, I believe, 2019 or 18. And if anything, they really felt that after all, disease in the liver behaved differently, and it probably would be amenable for the local therapy, add to the systemic therapy along the same time. So that's really one approach. Now, the second view is maybe we're not giving enough. And that's why the Emerald 3 study, which I disclosed that I'm one of the 3 lead on worldwide, mainly in Japan, China, and in the US. And if anything, double checkpoint inhibitor, anti-VEGF as well, could be this how much you need to really overwhelm the inflammatory response in the immune microenvironment of the tumor. So we don't know yet. So for today, at least the answer will be, please make sure you have your interaction with your colleagues in IR. Make sure that you really come to an agreement together, and we will, as such, wait until better days to really choose what will be best. And to choose among those 3 options, respectfully, I'm not an IR person. I'm not going to really give point one way or the other, but nonetheless, I'll comment on 2 things. I definitely do second Riyadh Salim in regard to the work and the TARE, because it really was the first and only one who really put in some references in regard to where we should use it, like with vascular involvement per se. But number two, the other thing is, in regard to, it's not like really who's the loudest voice in the tumor board, who really has most experience. If you really happen to have somebody who really is like the guru in regard to taste, guess what? Go for taste. And last point here, we have to be very thoughtful. And Dr. Akhade, you brought it up already, and I totally agree with you. We have to be careful what we are offering here because the cost is going to be an issue. And interestingly, in our study that we already published in JCO, we found that actually taste is the most commonly used therapy for liver cancer in Africa, where the highest incidence of liver cancer after Asia. So no doubt you have to go by experience and by cost as well.
Thank you. Thank you for insight. So let me move on. As you have touched upon that there are the other upcoming trials. We are trying to answer this question. So Dr. Tanios, let me ask you, which one of these trials you're looking forward to, or do you think the addition of IO or IO plus VEGF inhibitors won't add much as there is no OS to the previous two trials? What's your thought? If you try to look into crystal ball and try to guess.
Yeah, I think just to take a step back, I think OS is a very difficult measure here because of those patients are truly incurable in that sense for the most, unless you downstage them and in which many of them are actually some of them are ending up in surgery or even transplant. But assuming that take those patients that are truly will never see that day, they're going to progress at some point, and we're going to salvage them at some point, and that will affect survival. The question, I think, the most important question is there value for maintaining local control in this patient population? And this is a more difficult question to answer because, as you know, a lot of these tumors can be very bulky, symptomatic. They can affect liver function. So one can argue that if you can maintain a very strong DFS, PFS, and with maintaining the patient's performer status and capacity to receive further treatment, that with time, which is very difficult to measure in these individual studies, you may actually improve their survival as you have more and more effective therapies in the systemic setting. So I'd say I wouldn't take the negative yet completely as negative, and it still requires a question. Now, I think from these studies, they're all talent taste was reported, but if you look at essentially all these studies, they're all addressing similar questions, except when we look at the systemic therapy versus taste. Because when you look at Emerald and LEAP, the main question that wasn't asked is, can we just forego local regional therapy and just go with systemic therapy in this setting? And we don't know the answer to that. We have some patients who have significant responses with systemic therapy. I suspect that, you still need some level of local regional control. The other question that's important to ask also, to go back to Dr. Ghassan's initial discussion about neoadjuvant therapy, you can certainly consider, like they've tried to do a little bit with LEAP, a strong response to systemic therapy before you actually engage into local regional therapy. And that may actually be also a better strategy overall. So I think, if I want to look at this, I'd say the two main things, and one is missing here, of course. I think it was in a different slide, but the two main things that I look forward to is to see if systemic therapy actually can replace local regional therapy. And the other one is, what is the role of all this with TARE? At Mayo Clinic, we pretty much have not done TACE anymore across our sites, and we've moved primarily to do TARE for all patients, which, some studies suggest that it may have a little bit of an advantage. Maybe, I'd say maybe. It has to be really in highly specialized hands. But overall, these are the things I'm looking forward to.
Thank you. So moving on now, this is something new that I read a few days back in Annals of Surgery, a paper about histotripsy. So it was some ultrasound guided, and I'm very surprised at how Annals of Surgery, a reputed journal, end up publishing this, and it is a single arm study, a lot of criticism about the trial. So I don't think so. It is something that to be recommended, and I'm not so sure any one of you has any experience about this, but it is an Annals of Surgery publication.
Yeah.
Okay.
To
So
be fair,
any comments about this?
yeah, to be fair, we probably can have the same reactions like we just did, Dr. Akhade. And to be fair, there's one of the things that we're seeing a lot in medicine these days, and this is not to undermine dystrophy or anything else, but sadly, sometimes the marketing is ahead of the product medical evaluations. Nonetheless, we had a very open mind here at Moonstone Catering, and we are at least learning and talking to them and see what this means and what does it mean and who patient might be benefit from and what exactly mechanism per se. So I would say our experience is still super duper limited, if at all, maybe close to inexistent. But nonetheless, we are open to kind of discussion, and we're talking to the company to really understand better about the process per se, and try to really make sense out of it. So this is where we are at this point in time. So open mind, but at the same time, just learn more.
Thank you. Thank you.
I think it does, like, I do a lot of neuroendocrine tumors too, apart from HCC. And so, liver-directed therapies and histotripsy, as Dr. Abou very nicely put, I think the enthusiasm is ahead of the evidence for that therapy. Just like we had ctDNA in this too. It is, yes, it has a role, right? We have a lot of patients where ablative options are not possible because of their closeness to a blood vessel, all these other sort of issues where we cannot do local therapy and where there's a potential option for histotripsy. But is it better than any of our available therapies? There's no data about it at this point in time for it to like say that, oh, this is the way to go. That's how we think about it.
Thank you. So we still have a lot to learn from this. So moving on, the systemic therapy, unfortunately, most of our patients end up requiring this. And as you see, the first breakthrough was in 2007, then it required almost 13 years for atezobev to come up. And then there are some other regimens, including the Himalaya trial for which Dr. Ghassan is the PI, has come up. And looking at, this is a nice slide, which is showing how the median OS has improved from 10.7 to 13.6 to 19.2, and of course Himalaya 16.4 and 23.7 for the checkmate. So let me, of course, this is a summary slide, but now, of course, moving on, let me try to understand and let me ask Dr. Tanios your views about this particular OS curve, KM curves, crossing at around 12 months. So even though the checkmate regimen, that is the Nivo EP, is showing 23.7 months, that is the maximum reported OS, median OS, the curves are crossing in the middle at the rate of 12 months. So what is your thoughts on this, and how would you discuss or interpret this particular data?
This is one of the most confusing studies in many ways. Not only that the survival outcomes look a bit overblown compared to in the comparative arm, right? Because if you look at hazard ratios and deltas, they're not very different across all these studies. The median PFS of 9 months and being negative actually is interesting. That tells you that overall the patient population that entered the study outperformed historical comparisons. That's why I'm very careful about just taking the absolute number and blowing them off of proportion. Now, why do we see first, more patients possibly dying on the Nivo Epi versus, the Lenva sorafenib? Well, multiple reasons perhaps for that. One is, again, we know that immune therapy does extremely well for about 20-30% of the patients. But for the majority of the patients, immune therapy may add a little value to no value whatsoever. And then there is a subgroup of patients we believe are the hyperprogressors that actually their disease goes on fire on immune therapy. The last thing I would say that, remember, this is high dose epi. A lot of patients had, and during that duration, a lot of toxicities may have dropped off, may have not been able to continue treatment. And we know that there were significant discontinuation in about, I think, 15% of the patients. So there was a significant element that limited limited, perhaps in the initial phases, benefit. Now, as I said one time, it's always when you look at the tail of the curves, it's survival of the fittest. Whomever is able to make it to the end is the one that's going to benefit the most. And so that's why you see that separation happening later, whereby at the beginning it's Hunger Games. A lot of people actually are lost to benefit the few. So when you put all this together with all the other studies that have been taking place in this disease, one can clearly say that the biggest unmet need in HCC for patients with immune-based therapies is a biomarker. Who are those patients that benefit the most? These are expensive, these can be quite toxic, and so we really need to understand how to select better those patients, frankly. So at this point of time, frankly, I don't look at this Nivo-Ipi combination as changing the landscape. I think it's an added option to patients, but I'm pretty turned off by the dose of the Ipi and its likelihood of toxicity. I would favor Tremi Durva if I choose a dual checkpoint inhibitor over this one, frankly.
Fine. So now, of course, we have a lot of China-based IOs which are coming up. I have made a summary about, of course, they are coming up in early, intermediate, and advanced stage also. And we have CARES 310, which was recently published with an OS of 22.1 versus 15.2, and it is approved in China. Now, if you have all the options available, and if the patient is fit, no contraindications, most of the people prefer atezolizumab because, of course, this is a first regimen to come. But choosing these particular drugs as the first-line regimen, as Dr. Tanios has said, the biomarker response are an unmet need. But let me ask Dr. Namrata, what is your the choice and how you choose if all the drugs are available and patient is fit, no contraindication?
I think I am part of that group that chose atezolizumab. That is my go-to regimen for pretty much most of my patients. I think the benefits, right? The long-term benefit of immunotherapy and dual IO and improving that, it to me is offset by the significant high risk of toxicity and the bet we take about only about 20 to 30% of those patients benefiting. I think VEGF has a lesser, dramatic response for like those small patients, but pretty much works better for most of the patients, I feel. And it's so well tolerated. Patients do so well on it. I personally feel I use atezolizumab as my frontline. There are patients like, Ipi-Nivo, right? There's always like this where it has a very slightly highest response rate of all the different regimens that we've talked about. But the three of Ipi is very toxic. It has scarred me over the years with the IO hepatitis I've gotten from it, or my patients have gotten from it, that I personally don't use that. But the Durva-Tremi regimen is very interesting, and I have used that obviously as a second option for my patients who I cannot give bevacizumab for because of variceal bleed or contraindications to bev. But my personal go-to regimen is atezolizumab.
Thank you, Dr. Ghassan. What's your thoughts? I know you're the PI of the Himalaya trial, but let me ask you frankly, what's your opinion?
With full disclosure, yes, I'm the PI and I led the Himalaya study all over the world, which is still the largest study ever, 1,300 patients.
Congratulations.
And I remember when I presented at GI ASCO the results of the of the Himalaya study. That same evening, Neil Love, whom runs beautiful work in regard to CME, he asked me a question. He said, "Whom will you give the Durva-Tremi to of your patient?" And I looked at them and said, "Everybody." I said, "Like what?" I said, "Yeah, absolutely everybody." And let me explain that. Number one, to be fair, if you ask me, how do these therapies compare? They all are doing the same thing. What you just did, Dr. Akhade, you put like a lineup for us on regard to survival. But we have to remember that we are really comparing here apples and oranges because we cannot really claim that the populations are the same. Demographics are really different quite a bit in those studies. And as an example, one of the many examples, in the IMbrave 150, 50% of the patients were actually hepatitis B as etiology, while in the Himalaya study, 30% were hepatitis B. And I add on, if we put the new CARES study, it was 75% of the patients were Hep B. And we have seen from David Pfister's study in Nature back in 2021 that Hep B will kind of enhance certain number of CD8 cells. They called them at that time exhausted CD8s, but we didn't know more about that until now. We know the Nobel Prize back in 2019 was based on the work of Jim Allison at Sloan Kettering for the anti-CTLA-4. And then here go in 2019, also again, the Nobel Prize was given for, correction, this year, 2025, was given for the FOXP3. And we can see that, in other words, the enhancers and potential activities of those checkpoint inhibitors is still to be understood better. And why do I say that? Because I could have said, okay, great, the more Hep B, the better you have outcome. And actually, to that matter, there was the AZ real-world data that came from London, and that showed actually mean survival for the Ambrave 150 was only 15 months, but only because they had only 30% of the patient Hep B. And then you bring in now the Ipi/Nivo, despite the caveats that I totally agree with Tony in regard to this is a very hard study yet to understand, and the crossover has a lot to be hidden that we still have to discover. Nonetheless, it has still survival, which is like 22 plus months. And why is that? Because clearly there's more variables than we can think of in regard to the enhancement of those checkpoint inhibitors. And could it be that the FOX3, could be some other components have played a role? We don't know. And this is one of the works that we're doing currently at Sloan Kettering. We're collecting actually data, demographics, as well as tissue from different cohorts around the world. Proudly, India is part of, and we're doing this with our colleagues at Tata. Number two is we're doing it from Korea, we're doing it from France, we're doing it from the Pacific Rim with all the islands in the Pacific, and of course in the US, in New York at Sloan Kettering. And we're trying to find out really who gets what, who benefits from what. And rather than us come to do those meetings and say X% will benefit or X% will not, can we really come to the day where we'll say this patient, because of the following profile of their tumor and their immune microenvironment, should get the following. And proudly, we just published yesterday, you probably saw it in ESMO Open, we actually part of the last paper that came out of the CLGB 80802 study of the doxorubicin plus sorafenib, negative study, but we looked into signatures radiologically that can tell us about where things are. And believe it or not, we have 16 signatures in regard to radiology alone that can tell us what patients might benefit from. You can imagine how more expensive this is going to be, extensive it's going to be for checkpoint inhibitors. So for today, I would say my choice today is correction. My first choice is durvalumab, tremelimumab. I will not use atezolizumab, bevacizumab, except if a patient already is on it, to just make sure I carry on with the same therapy. And however, the future will be, hopefully we'll choose based on what the patient profile is rather than by our choices.
Thank you. Thank you. Thank you for your thoughts. So moving on for second line, the Ankur, we don't have much options. If the patient has taken, say, atezo-bev or any other IO combination has progressed, right now, Lenva is the go-to regimen, the Ankur. Are you there?
So Dr. Ankur has logged out.
Okay. So let me move on. Dr. Tanios, what's your thoughts that in kidney cancer, we have seen that unfortunately IO after IO doesn't work much. So do you think in an hepatocellular carcinoma in future, will there be any role of IO re-challenge, or as of now, we have go-to regimen is only lenvatinib or any other TKI like ramucirumab or regorafenib or cabozantinib? So what's your thought on, can we re-challenge IO in HCC? Or do you do that in your practice? It's a longer disease interval.
Yeah, the short answer, incredibly and highly selectively and based on very little data. In kidney cancer, the data was obviously negative. In HCC, there is still some work ongoing. Most of the work comes from case reports. Now, if you start with atezo-bev and you have a really good response, which about 30% of the patients will, and you go beyond a few months and then you progress, the natural inclination is to go to a TKI, which makes sense. And if the patient is still performant, we may actually consider a dual checkpoint inhibitor. And I've done that, and we've had some responses. Most patients don't actually respond, but some do respond. but the response is also short-lived. So you have to really measure the pluses and minuses and whether there are other options, clinical trials or other. So I think beyond first line, we're still not doing well at all in this disease. So is there a role for post-IO? Maybe selectively based on anecdotal treatment, but we also have to think about the costs. So in your part of the world, is that a viable option? In our part of the world, it's becoming a more difficult option as well. So I think these are the considerations, and we have to wait on the final studies to continue to report out before making a general assumption. But I suspect it's a matter of selection, and you cannot re-challenge with the same. So if you fail the VEGF plus ICI and then you go to a TKI that targets VEGF, you don't want to go back to a VEGF inhibitor plus ICI, but you want to go completely and switch to a double checkpoint inhibitor. If you start with a double checkpoint inhibitor, I'm not sure that ultimately you're going to benefit from exposure to an ICI.
Dr. Ghassan, your thoughts on this?
Yeah, I would like to really probably correct all of us on one word. When we use checkpoint inhibitors, we should not call it re-challenge. We should call it actually a reminder. Because think about it, what are we doing? We're simply bringing some drugs like, the durvalumab, the atezo, etc. And what we're trying to do is we're trying to wake up our immune system, say, by the way, these are bad guys, just go after them. That's all what we're doing. And no doubt that our immune system is very capable of forgetting. And as we know, that's why we get vaccines every year and what have we, etc. And interestingly, in the Himalaya study, we did actually try to re-challenge with another tremelimumab dose if patients were to fail, and on one condition that they were rather doing okay. Stay tuned. This might come to a theater or a movie screen next to you soon, but nonetheless, I can tell you from hands-on experience, yes, some patients will benefit. In other words, they will really be on durvalumab, got the only dose of tremi, and then like a year later, they start losing response. They're still doing okay, but a little bit, you see the tumor growing. You give another tremi dose, and believe it or not, they respond again. So what we have to really think about here, can we really kind of like bring a reminder effect to that matter? And this is where I respectfully don't necessarily agree. Not that I know any different, but I don't necessarily say, as Tony's saying, that should not be the same thing. It depends what the reminder is for. Is it because there is a certain bypass and that's why, quote unquote, become like really a re-challenge of different therapy? Or is it a reminder effect where we're going to give the same therapy per se? We are not there yet. We are kind of like trying to make sense of all of that data. But at least I can tell you the only reason I will do what Tony is saying, and I agree on that one, if a patient fails very quickly on the atezolizumab, and sadly they can, this is one that definitely I'll switch to a different therapy, durvalumab. But why do I do this? It's not because of considered gained resistance right away. It's because more likely than not, as we know, 30% of patients on the atezolizumab have anti-drug antibody, where the atezolizumab will be totally ineffective. And that's probably what patient you consider as if they never got checkpoint inhibitors. That's why you just provide them with that opportunity with the durvalumab.
Thank you. Thank you. So let us move on, and we're running out of the time. So as far as where is the next blockbuster drug in HCC going to come, whether it's going to TIGIT, Morpheus is a small phase 2 study. We require a larger study to prove TIGIT has anti-TIGIT drugs have unfortunately failed in other solid tumors. We have bispecific antibodies. We have CAR T cell therapies. So let me ask Dr. Namrata, we had a prolonged wait from 2007 to 2020, 13 years for a new blockbuster drug to come. So according to you, where is the next blockbuster drug in HCC?
Well, it's not
Is it
TIGIT.
CAR T?
I think
Is it bispecific? Where?
I think at least it's not TIGIT. That's we know because we have the phase 3 study. I think it was presented recently from the the follow-up of Morpheus, which was a negative trial, unfortunately. So that's not the answer. I think there's a lot of different ways people are looking at, right? There's radioligand therapy targeting, GPC and other like proteins. There is, I'm kind of excited about that coming from the neuroendocrine world, as you know. I like radioligand therapy has something that we had that changed the face of that disease too. There is, CAR T cell therapies. I think we probably, I'm not by specifics, maybe, yeah, that sure is also another area. But I don't think any of these are ready for like that, hey, tomorrow they're going to change what we're doing. It took time, such a long time to get to these agents, and now we have so many options that we have to choose. That if they come to Philadelphia, they'll get atezobev, and if they go to New York, they would get a durvatremi, which is a great thing, right? For patients, you can pick and choose the best option for your patient. That's amazing. But I think as we move forward, there'll be all these different options that come in, and I think we definitely need to identify, the biggest unmet need is post-IO progression, or how can we end IO? Like, for what is the best option? I don't know. I wish I had that crystal ball. I buy those stocks and get rich, but I don't.
But Tanios, what is your thoughts? Where's the next blockbuster drug going to come? Or we're not looking at anything in the near future?
I don't think there's gonna be a blockbuster drug coming in the future. I think like we've done, it's gonna be baby steps, one by one. The question is, this disease has proven to actually respond relatively well to immune therapies. I actually think that CAR T cell therapy is likely to be part of the future. I'm not going to say it's the future because that means it's going to replace everything else, but it's going to be part of the future. And so, as it's making its way into lots of different solid tumors, not just HCC, but HCC is prime for that type of therapy. We've seen some early signals from some smaller trials. It looks pretty impressive. We've had these experiences here as well at Mayo. So I'd say cell therapy probably for the near future.
Dr. Ghassan, your last words. Which is the next?
I second with Tony. The future, I might, however, maybe be a little bit more kind of like firm on saying that checkpoint inhibitors did very good job. Remember, we have with the durvatremi, we have 6 years survival. 6 years, like number that we never thought of. 20% of patients still alive at 6 years. And we have CRs, patients that really are technically cured of the disease. So I think definitely it did a major impact in regard to the disease, which really the mean survival, just to let you go back, in 2020 was 3 months. And this is where we are today, 6 years. And add to this, I totally agree with Tony that the future is in CAR T. Cell therapy is definitely where things are going. As long as already we are defining first, we all agree that maybe, and this most of the sponsors and most of the investigators are looking into GPC3 as being the target, which we proudly published on almost 10, 15 years ago on GC33 that we led with our colleagues in Japan. But at the moment, we are trying to, Michelle Sadlin and myself, we're trying to really see how we can actually further load that car with further enhancers to really pierce through to get to the response that's needed. Will it be for everybody? I totally agree with Tony. It's not going to be for everybody, but I think the focus and the wealth is going to be coming from the cell therapy next. No question about it.
So we are coming to the end of our panel discussion, and I really thank all my faculties, Dr. Louis, Dr. Ankur, Dr. Namrata. She is in her clinic, as I see, and Dr. Tanios and Dr. Ghassan for taking out time, and it's a really wonderful discussion. And I hope our audience, which are oncologists mainly from India and across the world, have benefited. More than hundreds have joined it, and we will of course have a recording of this and we will share it. But I once again thank all of you, and I'm looking forward to more such discussions, and that's the end of it. So again, have a good day, great day ahead. Good morning, good afternoon, good evening from various parts of the world. Thank you.
Thank you, Ankur.
Thank you. Take care.
This was great, and
thank
really
you.
will contribute to all the great efforts you do. Thank you. Take care.
Bye-bye. Thanks.
Thanks.
Bye.
Thank you. Thank you. Bye.